Hello everyone, I'm Richard Conway from Dublin, Ireland, reporting for Room Now from ULR 2021. And I'm going to talk to you today about an oral presentation from Friday's session on rheumatoid arthritis, comorbidity and clinical aspects. This is by Dr. Helgren, and it's study OP0210 entitled Pregnancy Outcomes in Relation to Disease Activity and Anti-Rheumatic Treatment Strategies in Women with RA, a matched cohort study from Sweden and Denmark. So quite a mouthful of a title, but very informative as well. So this was a registry-based study in these two Scandinavian countries, and they had 1,739 RA pregnancies, and then matched them in a 1:10 ratio with 17,390 control pregnancies in patients who did not have RA. So what they found in this study was that RA increased the risk of both preterm birth and small for gestational age infants compared to controls, with an odds ratio of 1.9 for both. And this is something we kind of knew from other studies, that rheumatoid arthritis increases the risk of poorer pregnancy outcomes. And the big question on what this study then went on to look at is, why does it do this? Is it potentially related to the disease itself? Is it related to medications? Is it something else? And can we do anything about it? So when they broke this down into the disease activity as measured by DAS28, they found that those who had low disease activity, so less than 3.2, those RA patients did not have any increased risk for either preterm birth or small for gestational age infants. The odds ratios were essentially 1. But when they looked at those with higher disease activity, the odds ratios increased. And the higher you went, so if it was greater than 3.2 on the DAS28, it increased a bit. If you went greater than 5.1, it increased further. So it seemed that there was a direct relationship between the disease activity and the risk of poorer outcomes. They then went on and they compared rheumatoid arthritis patients who had disease activity of less than 3.2 on the DAS28 to those who had greater than 3.2, and looked at the comparative odds ratios for that. So this is comparing RA patients with low disease activity to RA patients with high disease activity. And they found that RA patients with high disease activity had an odds ratio of 2.7 for preterm birth, and an odds ratio of 3.4 for small for gestational age infants. So again, this is further reinforcing the fact that it really seems to be disease activity that is the risk here, not any of our treatments that we use in rheumatoid arthritis. And in fact, the follow on from this is that if you're using some of our agents to improve disease activity, that our medications should really be associated with improved pregnancy outcomes. And this is, I guess, something we should really do better in clinic. I think a lot of our patients, despite the fact that we tell them our medications are safe in pregnancy, we're not doing well at getting that message across. And a lot of patients still prefer to stop their medications during pregnancy with the best intentions. They don't want to be giving anything putting anything foreign into their body when the baby is developing. But I think we need to do better at bringing across this data, which in fact says that it's a risk to the baby not to be on these medicines, that the pregnancy and the baby are going to have worse outcomes if the rheumatoid arthritis isn't controlled. So really, we should continue these medications where safe during pregnancy. You can follow me at Twitter at Richard P.A. Conway, and remember to tune in to Room Now for more news and information from ULR 2021.